Okay. All right, everybody. So my thanks both to Kaylee Berner and Garrett Cooper, who contributed in humongous ways to these slides that I just kind of re-edited. So by background, there's a little over 1 million people in this country with HIV, but there continue to be about 37,000 new diagnoses every year, and about over 150,000 people have HIV but don't know it. And of course, these are the people who wind up transmitting it because they don't know it. They don't change their behaviors or they don't get into care and become undetectable. And, in addition to the MSM population in this country, people of Black and Latino heritage are primarily affected. Okay, our state has traditionally been a low prevalence, low incidence area for HIV, but we've seen a dramatic increase in cases since 2017, 2018, and especially a very high incidence in people who inject drugs. And in fact, in the last several years, the majority of new diagnoses in our state is associated with injection drug use, to the point where the CDC has said for the last outbreak that they investigated in 2021 in Charleston and Kanawha County, that this outbreak was the most concerning to them in the United States. So we are a hot spot. Here is what they call a vulnerability assessment that was done by the West Virginia Bureau for Public Health. And it shows you the rankings for counties considered vulnerable to the rapid spread of Hep C and or HIV. And you can see that this is really concentrated in the southern half of the state, and especially at the bottom in the southern coalfield area. But there's really no area that's like spared. So PrEP is short for pre-exposure prophylaxis, and it's the use of antiretrovirals to prevent acquisition of HIV, and can be used to protect people whether their risk is sexual contact or injection drug use. So we have 3 possibilities now. We have 2 oral drugs. So the combination of FTC and tenofovir, for which the brand name is Truvada, and this has been around long enough that it's actually generic. And then we also have FTC and tenofovir alafenamide, which is the brand name for that combination is Descovy. And we also have a drug that can be given as a long-acting injection in the gluteal muscle every 2 months, and the brand name for that is Apretude. And I'm going to stick with the brand names, not because I think brand names are groovy, but because it's less of a tongue twister to do that. So PrEP the medication is ideally part of a comprehensive plan, and that plan should include discussion with your patients about adherence, about condom use, about the risk of other sexually transmitted infections, and for people who inject drugs, other risk reduction methods like going to a syringe services program. So all sexually active adults and adolescents should receive information about PrEP. And I want to emphasize that because HIV has now spread to counties in this state that have never previously, from the beginning of the HIV epidemic, had a case recorded. So it is conceivable that no matter where you live in West Virginia, there is potential risk. And prescriptions for PrEP should be offered to people who say they want PrEP, right? Whether they report a risk or not, or whether they report sexual or injection drug behaviors that are risks for HIV, or if they've had a bacterial STI in the last 6 months, or if they have received a course of the acronym is PEP for post-exposure prophylaxis. So those are all those indications. So because of the way studies have been done, not all of these three options are FDA recommended for everybody. So Truvada has been the most widely studied and is recommended for all persons for all risks. Descovy is only recommended for people who have sexual risk, that's men and women, who are engaging in anal intercourse, but women who have receptive vaginal sex, studies have not been done in that population. And Apretude, the injectable, is recommended for all persons at sexual risk, but has never been studied in people with injection drug risk. And this is just a function of how how the studies have been done. Anybody who's licensed to prescribe can administer PrEP. You don't need any kind of specialization. And really, people in primary care, are in an ideal situation for offering PrEP to eligible patients. By the time you come see one of us infectious disease specialists, it's probably late in the game. So here's a flow chart for thinking about how to go about ascertaining whether somebody could benefit from PrEP. And the simplest way to do this is just to ask your patient, are you having sex with men, women, or both? Irrespective of whether they're teenagers or adults. And if they say yes, then there's these other questions that you ask, whether they have a known partner who has known HIV, or partners where you don't know, or whether they've had a bacterial STI. And if you get a yes to any of these answers, then you should prescribe PrEP. And if no is the answer to these questions, then you can discuss PrEP with your patient and prescribe it if, they say, yeah, I'd like to do that. So that's the sexual risk flow chart. And this slide is the injection drug flow chart. And you, just like you screen people for sexual activity, you screen everybody for substance use disorder, and you ask, have you ever injected any drugs? And if those answers down that pathway are yes, then this is a person who would benefit from PrEP. And if no is the answer to any of these questions, then once again, if the individual is interested in PrEP, it's perfectly reasonable to prescribe it for them. So is PrEP safe? So that we do not have any evidence of serious short or medium-term safety concerns. Actually, Truvada was FDA approved for PrEP in 2012 and approved for the treatment of HIV, I don't know, in 99 or 2000 or 2001. I actually chaired this session in 2012. It went on for 10 hours. It was a mind-boggling experience. And PrEP is safe, and actually can also be used in women who are pregnant and breastfeeding, because pregnancy is a situation in which there's an increased risk of acquiring HIV. And if a patient is already pregnant or considering becoming pregnant, then this is an opportunity to discuss whatever concerns they might have about taking medication with you. So the oral drugs are all excreted by the kidneys. So any drugs that decrease renal function can increase serum levels and therefore increase the risk of adverse effects. And the most common things that people would be taking are NSAIDs, maybe medications for herpes. But the most common side effects are mild nausea and headache, and usually these resolve within a week or so of taking the medication. For the injectable cabotegravir, the most common side effect is discomfort at the injection site. Actually, this can be like really uncomfortable. People can say, oh, and they don't really enjoy sitting down for a couple of days. So in terms of the evidence base, we have, as I mentioned earlier, multiple studies that have shown that PrEP is really effective when you take it. That's the real issue, is when you take it. And if the transmission route is sexual, then the effectiveness is really high, about 99%. But that requires that people be extremely adherent to taking the medication. For injection drug use, there is less effectiveness, and really, we only have a single study in this population, and it was a study that compared tenofovir alone to placebo. It was done in Thailand now probably 20 years ago. It's called the Bangkok study. And so I would tell you that our concept of what works for injection drug use is kind of an extrapolation from that single trial. So to get protective plasma levels, if you're doing the pill forms of PrEP, you have to take at least 4 doses a week out of the 7, because it's a once-a-day dosing. And they're even among men who have sex with men who have good adherence, there have been a few cases of HIV infection. And it takes a while to build up the right blood levels for maximum protection. So if your patient is engaging in receptive anal sex, then they have protective levels after about a week of daily use. But if they are heterosexual women who are having vaginal sex, or individuals whose primary risk is injection drug use, then they don't have protective levels until about 3 weeks of daily use. And this has got to do with penetration of the drug into various body compartments. So the most important assessment before people start PrEP is to make sure they don't already have HIV, because while these medications work fine for preventing HIV, for treatment, they do not constitute a complete regimen. So you need a negative test, and the ideal test is this 4th generation, the combined antigen antibody test. I think it would be hard now to find some lab that isn't doing this 4th generation test. You don't want to rely on these finger stick blood tests, because they only detect HIV antibody, but not HIV antigen. And antigen shows up far earlier, about 10, 11, 12 days after exposure, and antibody might not show up for 2 months. So you really don't want to rely on these finger stick tests or the oral rapid tests. These are just not sensitive enough. And you should think about the possibility that somebody might already have acute HIV because they have a history of recent exposure, or they have symptoms that are classic for sort of a mononucleosis-like syndrome. The other really important tests are renal function, because the nucleotide tenofovir and TAF can affect renal function. These are usually, the effect is small, and it's usually not clinically important and reverses with discontinuation of the drug. But every once in a while, there is a vulnerable person who develops renal failure, and including Fanconi syndrome. LFTs are valuable for, initial baseline screening if you're going to think about the injectable cabotegravir. And the last blood test that's important is testing for hepatitis B. And that's because the oral drugs are used to treat hepatitis B. And then if your patient decides to suddenly stop taking PrEP, they can experience a hepatitis B flare. And hepatitis B flares can be serious. So while chronic hepatitis B infection isn't a contraindication to receiving PrEP, your patient needs to be aware that they should not discontinue the medication without having a conversation with you, so that you can monitor their liver function in case their hepatitis B reactivates. ongoing assessments are every 3 months for the oral drugs and every 2 months for the injectable. And the reason the injectable is different is because that's how often the injection is given. So they have to come in for this injection. It has to be administered by a skilled nurse. This is a 3 ml injection. So, normally we think of 2 mLs as being sort of the maximum volume, that maximum volume for an IM injection. So it takes some real skill, and you got to bury it really deep in the gluteal muscle. For the oral drugs, depending on their age and their estimated creatinine clearance, they need to have their renal function checked either every 6 or every 12 months. If they're on Descovy, the combination that includes tenofovir alafenamide, then they should get a lipid panel before initiating medication, and then once a year. And bacterial STIs should routinely be screened. And you can see what the asterisk and the little star, the little cross mean. The asterisks are for men and transgender women who have sex with men, should be checked every 3 months, but for the cabotegravir every 4, because you're trying to do multiples of 2 months. And then for heterosexually active men and women, it's more like once or twice a year. Now, here is the most important thing to know about the injectable. There's been a lot of enthusiasm about this form of PrEP, first of all, because you don't need to take a pill every day, though you do need to show up at a medical office every 2 months for the injection. And especially this has been hailed as a good thing for people who would have trouble with adherence for taking a pill every day, or for people whose lives are chaotic or have the possibility of being chaotic, like people who inject drugs. But there is an issue here if you stop coming back for the injections, and that is called the tail phase. And you can see that in the upper right-hand corner. You see the curves, the 2 peaks are the every 2 months injections. But if you stop the injections, the levels wane really slowly over time. And you have a 7-day window. So let's say they're due on May 1st, where they can come in a week early or a week late, but they shouldn't really come in at a greater remove than that, because you can see that at the lowest level, it starts to cross below the line that is the level that is necessary to prevent getting infected. And if someone discontinues injectable PrEP, but they're continuing to, whatever their risk behaviors are, sex and or injection drug, then they need to be covered with the oral medication. So just think about this. You're maybe offering the injectable to someone who has concerns about taking a pill every day, and then they decide to stop the injectable. Well, they're still injecting, or they're still having sex. Then they gotta take the pill every day for up to a year, because these levels wane really, really slowly. And the risk here is that if someone is not protected while these cabotegravir levels decline, they're not protected by the oral PrEP, then they can develop resistance to cabotegravir. And cabotegravir is an integrase inhibitor, and integrase inhibitors are cornerstone of treatment for HIV these days. So if you become good and resistant to an integrase inhibitor, then you're stuck with older drugs that are much less easy to take and have more side effects. So most insurance plans, and certainly West Virginia Medicaid, covers PrEP, although you might have to go through a PA process. There is a patient's assistance program. There's the 800 number, or the website. Copay assistance is available from Gilead, and I believe also ViiV, that makes cabotegravir. Here is a slide that has all of the websites for more information. The PrEP guidelines were last updated by the CDC in 2021. Then there's a PrEP line that you can get, you know, 9 to 8 our time, you can get questions answered. And then, you know, each of the manufacturers has a website for their form of PrEP. And there's indeed more websites information. And I think that's it. And I am happy to answer your questions.
Thank you so very much, Dr. Feinberg. Excellent, efficient as always. Does anybody have any questions?
I'm just sitting here trying to figure out how to work it into all the conversations it needs to be in.
Yeah, you know, Dr. Rexroad, that's a real issue. But I think, you know, certainly there's something called a SISC, a single item substance use questionnaire. I mean, that would, you know, there's a single question you can ask every patient to see if they have opioid use disorder. And then since the vast majority of people who have opioid use disorder have or continue to inject, that's kind of a both an important thing to know for their overall management and certainly for assessing their risk for Hep C and Hep B and HIV. But yeah, like everything else, it's another piece of your 15-minute visit.
Yeah.
I gotcha.
But it's good to know about the coverage and all that. I have prescribed it for a few folks, but as you pointed out, adherence is it's an issue with a lot of these folks.
Absolutely it is. I mean, I think that, you know, in many ways, it may turn out to be easier in general to think about oral PrEP because, you know, if you don't have hepatitis B, you can stop it, nothing happens. And if you have chronic hepatitis B, you know, and you know which patients of yours they are, you can say, you know, if you stop, you got to come in for blood tests. I think the injectable presents a little bit more of a problem because the reason you would tend to want to offer the injectable form to somebody is because they're not good pill takers or they don't want to be pill takers. But, you know, if and when they stop the injections, you know, then they're kind of committed to taking a pill and not for just a few weeks, but for many, many months. And, you know, it's interesting to me as somebody who spends a lot of time working with people with substance use disorder, that, you know, there are a lot of experts saying this is great for people who have substance use disorder, but maybe not so great because I would tell you that in my experience of prescribing PrEP, more people stop than continue forever. And so you really have to, you know, you and the patient really have to think about that. You know, the odds that someone's going to start some form of PrEP and take it for years is not high in my experience. You know, even among men who have sex with men who seek PrEP out. I ran a PrEP clinic at the University of Cincinnati. And, you know, if you're sort of young and healthy and don't need to take medicine, it's a burden. And people get bored doing it. They say, you know, I don't want to do this anymore. And so it's always, as I said, a little interesting and a little troublesome to me that people think that the injectable form would be just fine for people who have substance use disorder because not, you know, this is not ideally a population in which a commitment to daily medication for a long period of time is, you know, is going to be workable, especially because so many of them also are homeless that, you know, it's not just a matter of showing up and bearing your backside. There's downstream issues you have to think about. There you go. Have you tried the injectable or just the oral?
Just the oral.
And what have people said to you? Have they complained? It's okay, they don't mind it?
Haven't minded. I mean, exactly what you said, some nausea at first. But you know, if you can coach them through that and get them to persist, then it seems to be well tolerated.
Right. Sometimes you can, you can also give somebody a prescription, a short-term prescription for, nausea and say, here, if you have nausea and it bugs you, take this for a week. I mean, that's what I've done. Or, a
Yeah.
headache, tell them take Tylenol. And, tachyphylaxis is it's a rare person who cannot take Truvada or Descovy.
Truvada's been the one that I've used.
Yeah, I mean, I can't even I have to think of my memory banks of anybody I've ever given that to for either HIV treatment or PrEP that couldn't take it. It's pretty rare for people not to adapt, to the initial side effects, but you can make it easier for people by giving them, a week's worth of Compazine or something. Okay, any other questions for me? All right, Elizabeth, I'm going to turn it back to you.
Awesome. Well, thank you so very much again, Dr. Feinberg. And those slides will be in the content of iEcho and the YouTube video. So yes, again, thank you. Haley says thank you as well. The next time we meet will be on May 9th, and then you'll be discussing Hep B at that point. So we do have a case for that day too. So we look forward to seeing you guys. Thank you so much and have a great rest of your week.
Thank you all. Have a good week.